Varicose veins are enlarged, swollen, and twisting veins of the lower limbs, often appearing blue or dark purple in color. Okay, these are the varicose veins in the legs here. They are swollen, enlarged, elongated, twisting, and at times also tortuous. Okay, these are the words that I use to describe varicose veins. They happen when faulty valves in the veins allow blood flow to flow in the wrong direction or to pool in the superficial veins. More than 23% of all adults are thought to be affected by varicose veins. To understand the mechanism of varicose veins is very important to appreciate the venous anatomy of the lower limb. There are two main systems, the deep system, the dark blue, dark brown here, and a superficial system, the shaded in blue. Okay, the superficial system and the deep systems drain the lower limb of blood into the femoral system, femoral vein and above. The deep veins have got multiple valves along its course which prevent the backflow of blood as the muscles or the muscle pump in the calf and the thigh contract to expel the blood upwards towards the heart. The superficial system drains the blood from the superficial part of the limb into the deep systems through a number of deep perforators in the calf, the lower end of the leg, and the thigh. This diagram here shows you the superficial system, which consists of a long subvenous vein and a short subvenous vein. Okay, two superficial systems which have got perforators connecting the superficial veins to the deep veins in the lower end of the leg, below the knee, and in the middle, lower part of the thigh. It's very important to understand, to appreciate the anatomy at the saphenofemoral junction. The long saphenous vein enters below the inguinal ligament into the femoral vein, and this junction is of utmost importance, okay, because most of the times the pathology of varicose veins is the incompetence of this SF junction. Okay, this slide here shows you the deep and superficial systems of the leg. Okay, this is the deep system which pumps the blood upwards into towards the heart, and the superficial system also pumps the blood to the deep system at the saphenofemoral junction, as well as at perforators connecting veins, deep connecting veins in the lower part of the thigh, below the knee, and above the ankle. These are the three sites for perforator veins. Okay, the incompetence of these valves in these deep perforators and the deep veins constitute to the development or formation of varicose veins. In the superficial system, the veins become tortuous and dilated with blood that does not adequately empty into the deep system. Varicose veins, how do they come about? Veins have one-way valves so that the blood can travel in one direction, and usually is from the periphery, from the foot, down to the heart. If the walls of the veins become stretched and less flexible, elastic, the valves may get weaker. Okay, when the walls become stretched, so the valves become weaker and become incompetent. A weakened valve can allow blood to leak backwards and eventually flow into the opposite direction And when this occurs, blood can accumulate in the veins, which then become enlarged and swollen. So the backflow is from the deep to the superficial system, which is abnormal. The veins furthest from the heart are most often affected, such as the veins in the legs. This is because gravity makes it harder for the blood to flow back to the heart. Increased intra-abdominal pressure has the potential to cause varicose veins. These include pregnancy, constipation, pelvic tumors. Okay, veins, as I said, can be classified. Varicose veins can be classified into primary and secondary. 98% of the veins are primary, in which the cause is not known. The secondary causes of varicose veins include deep vein thrombosis, pelvic masses, example pregnancy, uterine fibroid and ovarian masses, and AV malformations, such as in the case of the Hippel-Trenone syndrome. This slide, we talk about the risk factors. As I said, the majority of the causes is idiopathic. It's known as primary or idiopathic, where the cause is not known. But the three main factors that contribute to this varicose veins will be a defective or weakening of the vein wall of the vein, where the vein becomes overstretched. Secondly, there's a defective in the valves. Okay, the valves become incompetent and allows backflow of blood. And also another factor that is important is the muscle pump, especially the calf, where it is very useful, very important that the muscle pump is effective in pumping the blood back to the heart. So the potential risk factors include gender. Okay, the varicose veins mainly affect women more than males, and that may be the reason why the female hormones may be the cause which relax the veins. And that is the reason why patients on OCP and HRT have higher incidence of varicose veins. Genetics, where the varicose veins tend to run in the families. Obesity, being overweight or obese increases the risk of varicose vein. Age, advancing age, due to the wear and tear of these veins, it predisposes to varicose veins. And certain jobs, where the individual has to spend long hours of standing at work, may have a higher chance of developing varicose veins. Pregnancy, for obvious reasons, hormonal changes, as well as the gravid uterus causes pressure on the pelvic veins, will predispose to varicose veins, and it is higher in postmenopausal women. The clinical features of varicose veins. Okay, varicose veins patients will typically present initially with cosmetic issues like dilated and unsightly veins visible in the legs, or the discoloration of the skin. Worsening varicose veins may then cause aching or itching over the area, and subsequent complications, if left untreated, can include skin changes, skin ulceration, thrombophlebitis, or bleeding, often presenting post-trauma. On examination, the varicosities will be present in the course of the long or great or short saphenous veins. They can also present with features of chronic venous insufficiency, such as ulceration, varicose eczema, or hemosiderin deposits. Now, what is restless leg syndrome? This is the uncontrollable urge to move your legs, usually because of uncomfortable sensation. It typically happens in the evenings or nighttime when you are sitting or lying down. And moving the limb eases the unpleasant feeling. Okay, this is the very frequent presentation of varicose veins, especially early varicose veins is known as restless leg syndrome, RLS. So this picture shows you the stages of varicose vein. Here is a patient with normal legs, no varicose veins. Stage 1, you have reticular veins or spider veins seen on the leg, especially the lower leg. Stage 2, varicose veins or venous nodes develop. They become bigger and they appear as nodes. And these are the stage 2 varicose veins. Stage 3, where they develop chronic eczema over the lower leg. Besides the varicose veins, you also develop eczema and skin changes. And stage 4 is when varicose eczema or ulceration takes place, usually at the lower part of the lower third of the medial aspect of the leg. This slide shows you a clinical classification of varicose veins. C0 is when there's no venous disease, and C6, the other extreme, when there's extensive skin changes with active ulceration. C1 to C5 are different grades of the disease between the two extremes. This slide shows you the various grades of varicose veins. This is a telangiectasia or spider nevi, which is superficial engorgement of veins. This is a chronic venous insufficiency of the leg leading to changes, skin changes with discoloration and scaly or eczema of the lower end of the foot of the leg. This is a chronic venous congestion causing discoloration, fibrosis, and thickening. Changes known as lipodermatofibrosis due to hemosiderin deposits. This is a chronic ulcer, venous ulcer at the lower end, classically the lower end of the medial aspect of the leg. Here, various categories of healing. This is a bleeding varicose vein. These veins, which are engorged, tend to bleed on minor trauma. And this is a chronic eczema over the lower end of the leg, which is the most common site for varicose veins. A word about Saphenous varix. The Saphenous varix is a dilatation of the saphenous vein at the saphenofemoral junction in the groin, where the long saphenous vein joins the femoral vein at the groin. It may display a cough impulse, which is commonly mistaken for a femoral hernia. Suspicion should be raised in any suspected femoral hernia if the patient has concurrent varicose veins in the rest of the limb. These can best be identified using duplex ultrasound and management via high saphenous ligation. What are the investigations that can be done for varicose veins? Varicose veins are easily diagnosed by a physical examination, inspection, and palpation. Then this should be followed by some special tests, and the two important tests are the Trendelenburg test, which is also nowadays known as the tourniquet test, and Perthe's test. Following this, many of these tests are now becoming less and less used because we have better methods of detecting varicose veins, such as the Doppler test and the color duplex ultrasound scan. Doppler test ultrasound scan to check for the direction of flow in the veins. This can also give check for the blood clots or obstruction in the veins. Nowadays, with color duplex ultrasound, we have color images of the structure of veins, which helps to identify any abnormalities and can also help to measure the speed of flow. So any regurgitation or slowing down of the flow of blood can be detected by means of this color duplex ultrasound. I mentioned venogram here because in cases where you're unable to determine deep vein thrombosis, then venogram is the most reliable investigation, which may have to be done especially in patients who are planned for surgery. How do you prevent varicose veins? Reduce the risk of developing varicose veins. Get plenty of exercise, especially walking. Maintain a healthy diet. Avoid standing too long. Do not sit with legs crossed. Sit or sleep with your feet raised on a pillow or two. And anyone who has to stand for their job for long hours should try to move around at least once in 30 minutes. What are the complications of varicose veins? This is a long list of complications, of which the top 3 are the most common. Skin changes, eczema, lipodermatosclerosis due to deposition of hemosiderin, ulceration leading to infection and pain, bleeding. These dilated veins can be easily traumatized and cause bleeding due to rupture, malignant change, deformity, cosmetic, and DVT. Now we come to the management of varicose veins. The primary aim in the treatment of varicose vein is to reduce the venous pressure. This can be done by a number of ways. The non-invasive methods include, first, patient education on avoiding prolonged standing, decreasing this weight, and also regular exercise to promote the calf muscle action, which will improve the blood flow in the limbs. The other method is compression stockings. Advise the patient wear graded pressure compression stockings, and this will improve the symptoms, relief of symptoms, and also prevent ulceration. The main drawback of these compression stockings is the compliance of the patient. The other important thing is we must ensure the patient does not have a peripheral arterial insufficiency, because compression bandages or stockings will worsen the arterial or circulation in the lower limb. Therefore, it is utmost that you do an ankle brachial pressure index before advising the use of compression stocking. The other important and easy and common method is to elevate the leg to reduce the pressure. This can be done by using elevating the legs on 1 or 2 pillows, especially when the patient is lying down. Medications can be used to improve the tone of the veins. The venous tone can be improved by using medications like Deflon 500. This slide tries to explain how elevation will alleviate the pain and swelling in varicose veins. Okay, varicose veins are due to poor return of venous blood back to the heart from the lower limb, and if you elevate the leg, this will facilitate the drainage by gravity. Okay, you can see before elevation and after elevation, the varicose veins are very much less. Same thing here, varicose veins before and after elevation of the leg. Now we come to a bit more details of these compression stockings, which is a very commonly used method for treating varicose veins. These compression stockings are also known as graded pressure stockings. The pressure at the lower end of the stockings is much higher compared to the one at the thigh. The purpose or the mechanism is to squeeze the patient's legs and improve the circulation and venous return to the heart. As I said, they are graded. They are tight around the ankles and looser further up along the leg and thigh. Use of compression stockings may help. It will definitely help with the discomfort, pain and swelling of the for the patient. But it is unsure whether it stops the varicose veins from worsening or even prevent them. In fact, one of the complications of using long-term use of compression stocking, in some people it makes the skin dry and flaky, and it's also very uncomfortable, especially in hot weather. So as I said, compliance is a major issue with compression stockings. This is a slide to show you the role of graded pressure stocking for varicose veins. These stockings are pressure graded. Okay, their pressure at the lower, compression pressure at the lower end is much higher than the upper end. So the pressure is applied at the ankle and the lower leg is much higher, is tighter, the stocking here compared to the thighs. So this is the graded pressure stocking for varicose vein. Again, in summary, pain, huge varicosities, repeated bleeding and non-healing ulcers are the indications for surgery. So in summary, the surgical intervention will be endovascular ablation using laser or radio frequency, high ligation, which I will highlight what it is in a short while, stripping of the varicose vein, avulsion of the varicose vein, and injection of or ligation of the deep perforators in the leg. And what are the treatment options available for varicose veins? Vein ligation, stripping and avulsion is one of the most commonly used surgical treatments for varicose vein. This involves making an incision in the groin or popliteal fossa and identifying the responsible refluxing vein before tying it off and stripping the vein and it's away from the leg. Care must be taken because this stripping of these varicose veins can result in saphenous and sural nerve injury. Next treatment available is called foam sclerotherapy, which involves the injection of sclerosing agent, which is an irritating agent, directly into the varicose veins, causing an inflammatory response and subsequent fibrosis of the vein. This is done under ultrasound guidance to ensure the foam or the irritant does not enter the deep venous system and cause DVT. The third treatment available is the thermal ablation, which involves heating the vein from inside, either using radio frequency or laser catheters. This is also done under ultrasound guidance and is generally known as the endoscopic or endovascular ablation of varicose veins. Okay, now I'll briefly tell you what high ligation and stripping is all about. Okay, this is the leg of the patient, showing you the superficial venous system and the SF junction here. So make an incision in the groin to expose the saphenofemoral junction as shown here and identify the tributaries of this saphenofemoral vein, which is the external pudendal vein, superficial epigastric, superficial circumflex, and the medial accessory artery. Okay, so these are the common tributaries of the long saphenous vein just before it enters the femoral vein. So carefully identify this vein, this junction, and ligate off all these tributaries. At the same time, ligate the superficial long saphenous vein as close to the femoral vein as possible and transect the vein away from the femoral vein. Then a catheter is known as a vein stripper. Metallic vein stripper is then inserted into this long saphenous vein all the way right down to the ankle if possible, but in most cases at least until the popliteal region. And then you pull the stripper upwards from the incision here until the whole vein is stripped and removed from the leg. It can be similarly done to the superficial saphenous vein as well, introducing the stripper from the popliteal vein right down into the lateral part of the foot and stripping off the vein itself. Depends which system is predominantly the cause of the varicose veins. So this is known as high ligation of the saphenous vein and stripping of the long saphenous end together with the short saphenous vein. Sometimes if the varicosities are very big, then you may have to individually avulse the individual varicose veins, and that is known as avulsion. So this high ligation and stripping is one of the most common open surgical methods used for the treatment of very severe varicose veins with complications. Okay, this picture here shows you the metal stripper. Okay, it's got a T handle here for you to hold, and at the tip you can put various size strippers. Okay, the various sizes. Normally for the smaller veins you use the smaller stripper. The head of the stripper should be small, whereas the big veins you can use the big one. So you decide on the size dependent on the severity of the varicose veins. Once you have attached a head, you push the stripper down from the saphenous vein right down to the leg. Then at the tip where it is head is attached, and then once it's in place, you can slowly apply some traction and pull the dilator until it brings along with it the long saphenous vein. Okay, this is known as the stripping of the saphenous vein. This slide shows you the stripping of the long saphenous vein from the calf down to the ankle. A small incision is made here and the long saphenous vein is identified, a cut made, and to introduce the stripper. The head of the stripper is then fixed here and it is tied. Then using traction, this stripper is then pulled through and it pulls along the long saphenous vein and it comes out like this. Okay? This is the head of the stripper and this is the vein that is being stripped, and this is the segment of the vein that has been delivered out from up here. Now I'll take you through some simple examination of varicose veins, highlighting the tourniquet test and the Perthe test. First, introduce yourself to the patient. Wash your hands before you touch the patient. Briefly explain to the patient what the examination involves, what you can expect from the examination, especially pain and discomfort. Expose the patient adequately by asking him to remove their bottom stock clothing, exposing the entire lower limb. If necessary, offer a chaperon to the patient. Then start by inspecting of the patient, but be prepared to be instructed to move on quickly to certain sections by the patient, by the examiner. For varicose vein includes, first, look for signs associated with chronic venous insufficiency, CVI, and these include varicose eczema, hemosiderin staining. These are seen as brown patches or brownish discoloration, ulceration commonly located on the medial aspect just above the ankle, lipodermatosclerosis, which is hardening of the skin distally and also discoloration, swelling of the calf and the leg, presence of scars indicating previous surgery on the limb, and looking for obvious varicosities present in the lower limbs, inspecting both the long and short saphenous veins. Secondly, you also look for signs associated with arterial disease or arterial insufficiency, which will determine the suitability for compression therapy. These include the trophic signs of loss of hair, nail thickening or friability, ulceration, especially at the pressure points, and a very careful examination of the peripheral pulses. Trendelenburg or tourniquet test. The Trendelenburg test is a test of the saphenofemoral incompetence. With the patient lying supine and the veins from the leg drained, occlude the SF junction and then ask the patient to stand. If the varicose veins refill rapidly from below, then the source of the problem is below the SF junction. On the other hand, if on removing the occlusion at the SF junction, it fills from above, then the fault is at the SF junction. Next is the tourniquet test. It is a test of the SF incompetence and the deep perforators of the leg. Again, with the patient lying supine and the veins drained off, the tourniquet is placed around the upper thigh and the patient is asked to stand. If there's rapid filling above the tourniquet, then the saphenofemoral junction is faulty, is incompetent. If there's no filling from above, but rapid filling of the varicose veins from below, the fault is then below the tourniquet. It can be either in the popliteal vein, popliteal saphenous vein, or it can be at the deep perforators. This test is repeated with the tourniquet placed at 3 sites, 1 above and 2 below the knee, to localize the site of the deep perforators that are incompetent. Okay, now we consider how a tourniquet test is done and how to interpret the tourniquet test. Okay, this is a diagram of the lower limb showing you the saphenofemoral junction and also the saphenopopliteal junction at the knee. Okay, so first, with the patient lying supine, elevate the affected leg and drain out all the blood from the superficial veins until they are collapsed. All the varicosities are collapsed. Okay, next, put the tourniquet in the upper thigh, and once it is tight enough, okay, tight enough to compress effectively the superficial veins and block them. Then ask the patient to stand. With the tourniquet here, ask the patient to stand. When he stands, observe the filling of the long saphenous vein. If it fills from above, rapidly from above until the level of the tourniquet, then you can assume that the SF junction is incompetent. So the problem is primarily here. On the other hand, if this upper segment above the tourniquet is remains collapsed, and if the veins start filling from below the tourniquet, then you know the problem with the veins is below the tourniquet. Then it must be either at the saphenopopliteal junction, medial end of the thigh, where there are perforators, and also perforators in the upper and lower calf, lower leg. So repeat this Trendelenburg test with compressions at all these various levels, and then you will be able to diagnose the site of the incompetent perforators or incompetent valves. This is the tourniquet test to detect the site of incompetence, either at the saphenofemoral junction and the saphenopopliteal junction, or in the various deep perforators in the leg. Okay, this is the Brody Trendelenburg test. The patient is lying flat, the leg is elevated, and the veins are drained of blood. Then the patient is asked, there's occlusion over the, apply a finger to occlude the saphenofemoral junction and ask the patient to stand. If it does not fill from above, then the SF junction is at fault, is incompetent. This is a tourniquet test where a tourniquet is applied to the upper thigh, and similarly the patient is asked to stand. Okay, filling of the veins from below indicate there are problems of incompetence below the application of the tourniquet. Next, we come to Perthe's test. This is to assess the functioning of the deep veins, whether the deep veins are patent. With the patient again supine, place the tourniquet around the thigh. Ask the patient to raise their heels off the ground 10 times. That means you try to squeeze the calf muscles to act as a pump to squeeze the deep veins. Look for collapse of the superficial veins. Okay, the veins, by the deep veins being pumped, it sucks the blood from the superficial veins, which then should collapse. If the superficial vein collapses, that indicates deep veins are functioning, as blood is returning through the deep vein system as usual. If, however, the superficial veins remain dilated or it becomes more dilated, that suggests there may be a problem with the deep vein system, whether it is obstructed or there may be incompetent valves in the deep vein system that prevents the blood from draining from the superficial system. Then it is considered Perthe's test positive. So when Perthe's test is positive, it suggests deep vein problem, either deep vein thrombosis or incompetent veins or incompetent perforators. Next, we come to the Doppler ultrasound scan, which has become the most important investigation for venous varicose veins today. Okay, it is very helpful to assess the site of venous incompetence, which is most commonly at the saphenofemoral junction and or at the saphenopopliteal junction. So placing the probe over these junctions will help to determine whether there is any incompetence and reflux of blood. It also is used to assess the patency of the deep venous system. Okay, the deep venous system can be blocked either to DVT, or its function can be affected by incompetent valves and also the presence of Perthe. So the Doppler ultrasound can help to assess these situations by assessing the deep venous patency system situation. It consists of a duplex ultrasound, which incorporates the sound and image, produces not only the image, it also produces the sound of the blood flow. And nowadays we have this color Doppler ultrasound, which can also allow you to measure the speed of the arterial and venous flow. It can also help you to diagnose peripheral vascular conditions, which are very important to exclude, especially if you are considering compression treatment or surgery for varicose veins. Now, in summary, what are the key points to take home from this lecture? First, varicose veins are tortuous, dilated segments of vein associated with valvular incompetence. That is, first, the definition of varicose veins. Secondly, the risk factors for varicose veins include prolonged standing, obesity, pregnancy, and positive family history. Thirdly, most patients will simply be a cosmetic issue. For most patients, it will simply be a cosmetic issue. However, can present with pain, aching sensation, swelling, or itching. Then some form of treatment will have to be given to the patient, either conservative or surgical. The gold standard investigation for varicose veins these days is duplex ultrasound. Management options in those that meet the criteria or those who need surgery include vein ligation and stripping, foam sclerotherapy, and thermal ablation. So these are the 5 takeaway points about varicose veins after this short lecture.